Hello, I'm Nora Hanna, Chief Engagement Officer at Sun Health, and I'd like to welcome you to this episode of Coffee Connections. We created this series to help you stay connected to the latest developments in healthcare and wellness by hearing directly from experts in our community. The Sun Health Foundation is committed to ensuring that this region has access to the most recent medical and technological advancements, and that we attract the brightest and best practitioners for care. To that end, we are the exclusive philanthropic partner to Banner Boswell and Banner Del E. Webb Medical Centers. Our mission is to empower others to live longer, healthier, and more purposeful lives. So we're excited to be able to offer you this unique access to these valuable expert resources. Thank you for joining us and enjoy the presentation.
Rosso. I'm a breast surgical oncologist. I have been in the Northwest Valley for about 7 years. Before I went to medical school, I was actually an artist. And so you'll see some art in my presentations. I was studying art in college. I was getting my Bachelor of Fine Arts in actually human figure sculpture. And my grandmother, who had raised me, experienced a breast cancer recurrence. And so that really changed the trajectory of my life. And so I finished up my art degree, but I decided to go to medical school. So I added some science classes to my background, went to graduate school and then off to medical school to focus on breast cancer. All right, so today I'm going to talk about screening recommendations, and then we're going to kind of dive into some historical breast cancer treatments. I really want to take you on a journey from kind of how breast cancer was being treated historically, and then through some groundbreaking changes. We'll talk about some current day management and then the future of breast cancer treatment. So just an introduction, we know that in older adults, cancer in general has declined, but in younger patients, less than 50 years old, we're seeing an increase in cancer, kind of across the board, but especially in breast cancer, endocrine cancers, and GI cancers. The number of cancers have increased most in patients 30 to 39 years of age, and this falls in an age group that they're not getting screening mammograms yet. We recommend screening mammograms starting at age 40, but we are seeing a trend in younger and younger patients developing breast cancer. Over the past years, it has increased 19% in the age group from 30 to 39. And the question then becomes, why is this happening? We know that there are different risk factors that many young people are exposed to. We know that rising obesity rates may contribute to breast cancer development. Sedentary lifestyle can contribute. Poor sleep, excessive alcohol consumption is a risk factor of developing breast cancer and GI cancers. And exposure to environmental factors and carcinogens really yet to be identified. So when women are seen in the clinic, they are evaluated as far as their risk of developing breast cancer. When I see a patient with breast cancer, the conversation becomes about treatment. But when I see a patient without a diagnosis of breast cancer, the conversation really becomes, what is your personal risk? And we can offer patients a risk assessment based on their family history, different personal characteristics, like age at the start of their period, family history, any history of previous benign biopsies. There are several things we take into account to screen patients to see if they're high risk. And if their lifetime risk becomes greater than 20% based on these risk assessment calculators that I use, then we incorporate an MRI to their screening regimen. So patients who are considered high risk get a mammogram, which is standard. So an annual screening mammogram is the gold standard. Every year, every woman should get an annual screening mammogram. Beginning at age 40 if you're average risk, and there is no age limit to getting mammograms. The conversation rather becomes, if you're healthy enough to get a mammogram and you want to do something about a result that is found, get a mammogram. But we offer continued high-risk screening for patients if they're diagnosed early, and we do incorporate MRI as well. Having dense breast tissue is also a risk factor, and there is a federal law that in every mammogram report that you get, every letter in the mail that you receive, you should know your breast density. So it should be reported on those reports. So there are breast cancer disparities as well. I want to touch on some breast cancer disparities. Minority women are more likely to die of breast cancer, 127%, and 72% more likely to be diagnosed with breast cancer, and 58% more likely to be diagnosed with advanced breast cancer. We know that Black women are 42% more likely to die from breast cancer despite a roughly equal incidence of breast cancer. Black women are less likely to be diagnosed with early stage breast cancers, but twice as likely to die of breast cancer. So this is an active area of research because not everybody is the same with regard to their risk, and we do take that into account as well when developing our risk models. All right, so we know that lifestyle modification can influence risk. We know that exercising 150 minutes per week at a moderate intensity is recommended, and moderate intensity means different things to different people. I was talking to one of my patients and I accidentally said 150 minutes per day at a moderate intensity, and she looked at me very, very startled, and I corrected myself, but 150 minutes per week at a moderate intensity. So getting the blood flowing, getting the heart rate up a little bit, that means, like I said, different things to different people. We know that eating a kind of plant-based whole foods diet, higher in vegetable, fiber, legumes, beans, I misspelled beans, and limiting processed food and meat is important to maintain kind of a heart-healthy diet, and also has been shown to decrease the risk of cancer. We know that limiting alcohol to less than 3 drinks per week is recommended because excessive alcohol consumption has been shown to be detrimental in increasing your risk of breast cancer. As everybody I think in this room knows, smoking is bad for you, so don't smoke, don't start smoking. If you're smoking, please quit. That's the best thing you can do for yourself if you're smoking, is to quit smoking. And then maintaining your weight at a normal level. We know that excessive weight can produce more estrogen in the body and expose your breast tissue to more estrogen, which can increase your risk of developing breast cancer. So these are modifications, things we can kind of change in our lifestyle for risk reduction. So I talked about our breast density. So breast density is a mammographic finding. It's not a physical exam finding, it's a mammographic finding. And the radiologist will characterize breast tissue as being not dense or dense. So there are 4 categorizations. The first one on your left is called fatty breast tissue. It is not dense, it's an easier tissue to screen with. It's kind of translucent on X-ray. The next one is called scattered fibroglandular densities. That is a not dense breast tissue. That is, again, easier to screen. If you think about it, a mammogram is like an X-ray of the breast, and Fatty tissue is more translucent on X-ray. But when we get to more functional breast tissue or more dense breast tissue, that really becomes an independent risk factor of developing breast cancer because there is just more breast tissue in the breast. In the last two pictures on your right are heterogeneously dense breast tissue and extremely dense breast tissue. So half of women screened have non-dense breast tissue and the other half has dense breast tissue. Okay, so that should be something that is reported on your mammogram result letter. We know that the amount of radiation in a mammogram is equal to about 7 weeks of ambient radiation living on Earth. It's actually equal to a flight on an airplane. So no one has ever died of radiation exposure secondary to mammograms. I know this can be a concern for some women who avoid mammograms and seek out other alternative screening methods. Just know that mammogram is the gold standard. It's FDA approved, it's the gold standard for breast cancer screening. Okay. And so this polar bear is going to help us kind of demonstrate what dense breast tissue means mammographically and how it sometimes can impede us identifying breast cancer. So you see on the left, there is a polar bear in a fatty breast. You can see the polar bear, it's very, very obvious, but in the extremely dense breast, it's harder to see. It's almost like a polar bear in a snowstorm. So that can represent a cancer kind of hiding in dense breast tissue. And so we've really transitioned from 2-dimensional mammography to 3D mammography, which identifies smaller masses in the breast. So if you go to the Women's Imaging Center inside Del Webb Hospital, you will guaranteed get a 3D mammogram. The trend now is to do 3D mammograms as a baseline screening study. And again, you can see the very, very small cancer detected on the fatty breasts with that red arrow. And then the much larger cancer circled on the right is hidden in dense breast tissue. That kind of gives you an idea of different screening modalities and really your breast tissue and kind of what it looks like on mammogram. All right, so I made this illustration to really kind of educate people about doing breast self-exams. So as we talked about, women are more likely to get breast cancer than men. 1 in 8 women will develop breast cancer. 1 in 1,000 men will develop breast cancer. But it's very, very important because men do not get screening mammograms routinely. It's not recommended for men. It's very important to have body awareness even when you're a man and you don't think you're going to develop breast cancer. Just noticing any changes in your breast is very important. So there are different techniques to do a breast self-exam. You want to feel the tissue kind of up to your collarbone, out to the middle, and then to the side. And then under your breast, and notice any changes in size, any changes in color, any nipple or skin retraction, any rashes of the skin or nipple associated with inflammation or swelling, nipple discharge, any new lumps, any new lumps. Just don't ignore the signs of breast cancer. If you have any suspicion, let your doctor know, and they order what's called a diagnostic imaging study. So it's a diagnostic mammogram, which really focuses on an area of concern, as opposed to a screening study, which is looking at the whole breast. And they do an ultrasound as well. And if there's any abnormal finding, the radiologist will recommend a biopsy. All right. So again, the gold standard for breast cancer screening is mammograms annually, starting at age 40. For high-risk screening, we add in an MRI every year. So a high-risk patient will get an MRI every year, a mammogram every year, but something every 6 months. Okay. And the breast self-exam is really important because it allows you to have awareness between mammograms and detect anything new or different between your mammograms. I've diagnosed many patients, although it's not as common as screening detected breast cancer, but I have diagnosed patients with a cancer that has developed between mammograms. or when they're younger than 40 and they aren't routinely screening yet. If they notice any changes in their breasts, I have diagnosed breast cancer in very young patients who aren't being screened. So I have 2 boys at home, and we do a lot of story time because the little one doesn't like to sleep. That's why I have some gray hair and some bags under my eyes, but the little one does not like to sleep. So we do a lot of story time. So I'm gonna do kind of a story about breast cancer, okay? We're gonna kind of go from papyrus to Instagram in a half hour. So the first kind of historically recorded breast cancer was attributed to the Edwin Smith surgical papyrus in 3000 BC. There are Egyptian carvings that are shown with women with one breast, suggesting that there was a breast cancer treatment of some kind even in the 3000 BC era. These papyruses described breast cancer as incurable if it was cool to the touch, bulging, and spread all over the breast. And women, nowadays with screening detected breast cancers have a 60% lower mortality at 10 years and a 50% lower mortality at 20 years from diagnosis, because we are detecting these breast cancers early when they're not clinically apparent and treatable with a goal to cure the breast cancer. So the biggest risk factors of developing breast cancer are being a woman and getting older. Again, things we can't control. So in 400 BC, Hippocrates kind of thought about what causes breast cancer. It was a defined entity historically, and historical scientists were determining, what was the cause of breast cancer. And Hippocrates in 400 BC thought it was an imbalance of humors. So blood, phlegm, yellow and black bile were considered our body humors, and any imbalance in these substances was thought to increase breast cancer. We now know that breast cancer can be genetic, related to a genetic mutation, familial, caused by environmental factors, including smoking, obesity, alcohol consumption, long-term use of hormone replacement therapy, not related to humors. In the 1st century AD, Leonides of Alexandria, who was a Greek physician, described different surgical techniques in treating cancer. So he detailed his approach with using incision and cautery, or very hot tools to cure tumors. And the practice was removing kind of the whole tumor with wide negative margins, which is still our practice today. We remove the whole tumor surgically with wide negative margins, because we know that margins at the edge, untreated positive margins, can increase the risk of breast cancer recurrence at the surgical site. So he was onto something. Galen in 200 AD attributed breast cancer to black bile in the blood. He concluded, though, that this was a systemic disease, and this was the first historical count that breast cancer is a systemic disease. He kind of learned that cessation of menstruation was somehow linked to cancer. We know that ovarian suppression can reduce the risk of breast cancer in certain women related to the hormone fluctuations in our body. And he described the word crab to identify breast cancer because it had kind of on exam dilated veins around tumors. He also allowed surgical wounds to bleed freely to get rid of the black bile. That's something we don't do today. We do not let wounds bleed freely. But he was onto something with regard to breast cancer, thinking of breast cancer as a systemic disease. So today we treat breast cancer with local and systemic therapies. So local therapies include surgery and radiation. Systemic therapies include chemotherapy, endocrine therapy, immunomodulators, and again, we don't allow surgical wounds to bleed. This gentleman did learn how to operate, learn how to become kind of a historical surgeon in the kind of the pits of Rome with the gladiators. So he would be the one to kind of stitch up these horrible abdominal wounds with, the intestines out. He would be the one to stitch those gladiators up. So it's kind of an interesting guy. He learned a lot on the field. And then really in the 15th to 18th centuries, surgery was disentangled from the barber's trade. So historically, surgeons were barbers. And I tell my sons this when I cut their hair, that I am qualified to cut their hair because I am a surgeon. But in the 15th to 18th centuries, there was really a vast exploration of human anatomy. So this also intertwined with art. So artists were studying human anatomy. Da Vinci was illustrating human anatomy structures in his diaries. There was a multitude of theories as well to describe why breast cancer was developing in women. It was thought that it could be related to congealed milk, trauma, personality type even, if you could believe it, exposure to air, infection. They were still trying to figure out what caused breast cancer, but really during this era, artists and surgeons alike were really trying to understand human anatomy to better treat maladies. And then in the 1800s, with the advent of general anesthesia in 1840, surgery became something that could be done for longer periods of time. And these are paintings that represent the surgical suite or the surgical auditorium in the 1800s. You can see an anesthesiologist with a paper cone kind of blowing caustic chemicals into this woman's face as they operated on her, and dozens of students, mostly men, almost always men, were kind of learning in these unique surgical auditoriums. This was before people started washing their hands, wearing masks, and it was a very heroic endeavor to have surgery at this time. George Beatson was a Scottish surgeon in 1895. So at the end of the 1800s, there were a lot of surgeons defining different techniques and being able to learn the art of surgery because of general anesthesia. But he showed that removing ovaries of young women with breast cancer led to breast tumor shrinkage. And that's really because some tumors are very sensitive to hormones or estrogen, and removing a young woman's source of estrogen or her ovaries has been shown to shrink breast cancer. And this was adopted by many surgeons. So any women with breast cancer were having their ovaries removed, sometimes having their adrenal glands removed, pituitary resection. So that's something we don't do today. However, in certain high-risk patients, oophorectomy, or removing the tubes in ovaries, can decrease hormone receptor positive breast cancer risk. Nowadays, the tubes and ovaries are removed to decrease the risk of ovarian cancer in patients with BRCA gene mutations. All right, so this is Madame Marie Curie. She won 2 Nobel Prizes for the discovery of novel elements, polonium and radium. Radium therapy is kind of the current day radiation techniques that we use in breast cancer treatment. One of our local breast cancer treatments is radiation, and present day radiation has been shown to reduce the risk of breast cancer recurrence by 50%, 50%. But Madame Curie's studies led to the invention of X-ray technology, which without her spirit of innovation, we might not have had mammograms. So this is a critical tool, like I said, in the detection of breast cancer. She unfortunately died of aplastic anemia with high rates of radiation exposure. And this is the godfather of modern day surgery. His name's William Halsted. He was a surgeon in Johns Hopkins. He was known to be a cocaine and morphine addict during his professional career. And he also invented our kind of current day approach to breast cancer surgery. So he started performing radical mastectomies on patients with breast cancer. So a radical mastectomy, also known as a Halsted mastectomy, he described it reduces the risk of local recurrence of breast cancer by about 50%. He observed kind of before in kind of formulating this surgical technique, he traveled to Europe and he saw that women were having their clavicles removed, their ribs removed, their whole chest wall removed to resect breast cancer, and he said there should be a better way. So we know now that survival in breast cancer is not only linked to therapy with regard to surgical approaches, but it is also linked to really the tumor biology and how that tumor behaves. Stage at diagnosis, and then systemic therapies as well. All right, so this is an illustration from the 1984. This is a radical mastectomy. So I have done one of these surgeries in fellowship and one in practice. This is not a surgery we do frequently, but it was the standard approach to breast cancer treatment in the 18 and 1900s. There was emphasis on removing all the tissue in one piece, including the pectoralis major muscle, all the lymph nodes under the armpit, all the skin, and it was very, very disfiguring. But this is what was available to women with breast cancer for several generations. So this is an illustration that I did for a textbook describing a radical mastectomy on the left. So the radical mastectomy is not done anymore, very rarely. So we had to write a textbook chapter about it because surgeons just don't do it anymore, thank goodness. And this is a real picture of a woman who underwent a radical mastectomy. You can see her ribs right underneath the skin. This is very morbid, as you can tell, surgery. So up until the mid 1900s, so 1960, surgeons were still doing this procedure for breast cancer. This is Bernard Fisher. He is a surgeon and cancer pioneer. And he said, his famous quote was, "In God we trust, all others must have data." So he was a surgical scientist, and he postulated that breast cancer, again, is a systemic disease. So he knew there was a better way to treat breast cancer, okay? And we had to prove that scientifically. So he enrolled thousands and thousands of women to participate in certain studies to determine how better we can approach breast cancer, Okay, so this is a lot of information, but his first trial, the NSABP B04, compared a less radical surgery to the radical mastectomy and found that there was no difference. Okay, so he randomized women to a radical mastectomy and a total mastectomy. So the total mastectomy preserves the chest wall musculature. Okay, and he found no difference in survival. Patients at this time, though, did not receive any systemic therapy. Okay. So the next trial that he again recruited thousands of women to participate in was the NSABP B6 mastectomy versus breast conserving surgery. So he randomized women to undergo a total mastectomy, which is the picture on the top, to a lumpectomy surgery where the tumor is removed with a rim of normal tissue, but the breast was kept intact. And again, there was no survival advantage between being more aggressive surgically or having a lumpectomy. Okay, so now the American Society of Breast Surgeons consensus statement actually says in early stage breast cancer, we should try and preserve the breast because there is no difference in overall survival between a lumpectomy and a radical mastectomy, if you can believe it. Complication rates are lower in the lumpectomy surgery or breast conserving surgery. And we also started de-escalation of surgery in the axilla or in the armpit. You can see that this picture on the right shows a normal sized arm and then an arm with significant end-stage lymphedema. So lymphedema occurs when the lymph nodes under the armpit are removed and those lymphatic channels are disrupted. So that fluid that we accumulate throughout the day in our tissues can no longer go back into the circulation. And it kind of pools and accumulates in the arm, causing significant morbidity, significant swelling of the arm, and it's very difficult to treat. So even when I was in training to test lymph nodes under the armpit, we would have to take out the whole lymphatic basin, okay? And in the 1990s, this gentleman, Dr. Giuliano, and his colleagues, he's actually still in practice, so this is a modern day procedure. He invented the sentinel lymph node biopsy, where when we stage the axilla or the armpit with breast surgery, we inject blue dye and radioactive dye, and the dye gets taken up into the lymph nodes, and then we can selectively pick out the lymph nodes that are highest risk and determine if there is any cancer in the lymph nodes, okay? And then to kind of build on this, surgeons and internists got together about 8 years ago and determined kind of a set of guidelines called Choosing Wisely guidelines. And they looked at patients 70 years or older to determine if we're doing too much surgery on these patients in this age group. In patients with early stage, more favorable breast cancer, should we even test the lymph nodes? And so now we're kind of getting away with even testing the lymph nodes under the armpit if a patient fits into the Choosing Wisely criteria. So we are really scaling back surgery for breast cancer. So the current paradigm in breast cancer treatment is to maximize survival while decreasing side effects. Local regional treatments and systemic treatments combined have offered the best outcomes. So breast cancer is no longer treated with surgery alone. It's no longer treated with medication alone. We combine all of these to offer the best outcome. And the goal is to restore the patient. So I have some pictures about the, because we do still have to do mastectomies in certain patients, okay? It's not a surgical tool that has gone away yet. So if a patient has a large tumor or it's invading the skin, we have to do a mastectomy surgery. But the plastic surgery team can offer a tissue-based reconstruction, and this one's called a deep flap, or a deep inferior epigastric perforator flap, that uses abdominal tissue to rebuild the breast mound. So you can tell that the after pictures show kind of a tummy tuck scar, and this is where they take the tissue and rebuild the breast mound, and it offers a very nice result in these women. And this is a latissimus dorsi flap. Sometimes patients can't have that previous surgery, the deep flap, for one reason or another, usually their anatomy. So the latissimus flap can offer a reconstruction where we use the latissimus muscle, or the back muscle. If you remember back to the Olympics a few years ago, Michael Phelps is kind of a triangle-shaped gentleman. Those are big latissimus muscles, but those are the muscles we use to rebuild the breast mound. And it offers a very nice cosmetic result. And then this is a picture of nipple tattooing. This woman could not have her nipple saved during a mastectomy, but she was offered reconstruction. And then she had tattooed nipples on in 3D. And so I'm going to offer this service to our patients hopefully in the next month or two. We're kind of getting all set up for it. I've done so much training, and with my art background, it's just, it seems meant to be. So stay tuned for this. And this is a slide that would make my medical oncology colleagues cry, because it's so brief. It's just one slide describing advances in systemic therapy of breast cancer. So in the 1960s, the estrogen receptor was discovered. Okay, so estrogen receptors are on certain types of breast cancer, and we know that those types of breast cancer are fed by estrogen, and so now we can block the estrogen receptor and help decrease the risk of breast cancer development or recurrence. In 1981, another of Bernard Fisher's landmark trials, NSABP-B14, these are kind of a mouthful to say, looked at tamoxifen, or a hormone-blocking pill, versus a placebo, and found 20% risk reduction, or 20% reduction in overall mortality in these patients receiving tamoxifen for 5 years. So tamoxifen is still used today as part of our systemic breast cancer treatment in certain patients. In 1970s, we started targeting an enzyme that makes estrogen. It's called aromatase. And so in patients who are postmenopausal, we don't block estrogen, we rather block estrogen production by blocking the hormone that makes estrogen. We know that this is all contemporary, very big trials that have come out, and breast cancer care is really changing, on a daily basis. In 2013, we found that triple negative breast cancer, so breast cancer that was not sensitive to hormones, actually respond very well to platinum-based chemotherapy. And these other trials kind of identify that sometimes giving chemotherapy before surgery can improve overall survival, because at the time of surgery, if the patient does not have any residual cancer, if the chemo has gotten rid of all the cancer, then their prognosis may be better. Or if there is residual cancer, they're candidates for other systemic therapy that has been shown to improve overall survival. And this is the biology lesson you never knew you never wanted today. But this is really the cell cycle. And every cascade, every step in the cell cycle, which is really kind of when the cells multiply and divide, every step of the way, some brilliant scientist has learned how to block cell cycle progression in cancer cells. So there are all of these steps and drugs to target each and every one. So that as you know, Angelina Jolie is a famous actress. She was diagnosed with a BRCA gene mutation, so she never had breast cancer. but she was diagnosed with a BRCA gene mutation because her mother died of ovarian cancer. So she had genetic testing. She met with a genetic counselor, got a blood test that showed that she was high risk of developing breast cancer in her lifetime. With that gene mutation she had an 80% risk of developing breast cancer in her lifetime. So she opted for surgical risk reduction, which is bilateral risk reducing mastectomies. And breast cancer testing or genetic testing for breast cancer gene went up 64% after she kind of publicized her journey with breast cancer risk reducing surgery. So women with a BRCA1 gene mutation have a 60 to 80%, 87% lifetime risk of developing cancer, and having bilateral risk reducing mastectomies, they can reduce that risk by 90 to 95%. So that's another surgery that we offer. And then this is more recently. So we've gone from papyrus to Instagram. Here's Instagram. This is Olivia Munn, another actress. And a lot of these public figures are kind of becoming more open with their cancer journey to educate other people who might not know. This actress underwent a high-risk evaluation based on her family history. So her information was plugged into a risk assessment calculator. She was found to be high risk, and even after a normal mammogram, an MRI, which is more sensitive, did show a small early-stage breast cancer, and she underwent bilateral mastectomies. And if you recognize that gentleman with the mask on, that is Dr. Giuliano, who invented the sentinel lymph node biopsy. So he is at Cedars-Sinai. He's a lovely gentleman. So she said during this process that cancer doesn't care who you are. Yeah, that's a good question. So it is a definition of minority women with high risk of breast cancer. So we know that Black women have a higher risk of developing breast cancer. And a lot of these risk assessments, these calculators that we've developed over the years, are based on white women information. So we know that in patients who are not white, sometimes these risk assessment calculators can underestimate risk. So we really take into account family history and personal history, and we can also use genetic testing to really hone in on a person's risk as well. That is a great question. So screening in dense breast tissue and extremely dense breast tissue. So 3D mammograms are still the gold standard. 3D mammograms can look at dense breast tissue better than 2D mammograms. And then the supplemental imaging is based on your personal risk. So if you have a family history of breast cancer and dense breast tissue, you could be a candidate for MRI or ultrasound, but it's best to talk to your doctor and see what they recommend, or even talk to the radiologist when you get your mammogram. Yeah, where can you get access to supplemental screening in the frame of dense breast tissue? So, talking to your doctor and having your doctor, consider ordering screening ultrasounds or screening MRIs. Probably screening ultrasounds just financially are a little bit less expensive, but I would talk to your primary care doctor and see if they would recommend that. So supplemental screening, we do that in patients who are found to have a higher risk of developing breast cancer. So these risk assessment studies that I mentioned, if you're found to have, so they'll give you a number, a lifetime risk number, and if it's greater than 20%, then you would be a candidate for high risk screening, so an MRI and a mammogram.
Breast
Yeah, so that was one of the characteristics that was looked at when determining breast cancer risk. So we look at age of first period, age of first childbirth. We know that people who have children younger than 30 are a little bit more protected than older than 30, but really that risk is very, small in the grand scheme of things. That's just something we look at, and it's not, if you had a child, say at age 35 or 40 or didn't have children, that's not a single risk factor that we would look at and say, oh, you're obviously now high risk or low risk. Based on that, it's just more of the overall picture of your kind of personal characteristics that, when added all up together, may increase or decrease your breast cancer risk. Yeah, so lumpectomy versus mastectomy. So we know that the long-term survival outcome is equal. The risk of recurrence in the breast is slightly higher after a lumpectomy, but only about 1 to 2%. There is a risk of recurrence after mastectomy as well, but there, because we leave breast tissue obviously behind with a lumpectomy surgery, so there is a risk of recurrence, but it's exceedingly low. It does, unfortunately, if there is a breast cancer recurrence and they've been given radiation as is standard after a lumpectomy, reconstruction can be more difficult. But the flap reconstructions that I did show are done most, not exclusively, but in patients who have had radiation, because we can't just put an implant into a radiated area. It just doesn't heal. The implant doesn't take, the body heals differently, so getting your own tissue to rebuild a breast mound can be done in the frame of radiation, and is almost always the case. But yes, even after a mastectomy, there is a risk of recurrence. And so I try and counsel people about making a choice that is fear-based. So I'd say maybe 30 or 40% of women that I see in clinic, they say, I want them both off. I want double mastectomies. I don't care. I don't want to deal with this anymore. And we really reframe that conversation, okay? Because that is a fear-based approach. And when I sit down with people and really tell them that there's no difference between a lumpectomy and a mastectomy, and you don't have to have your other breast removed, the chances are you're not going to have a breast cancer in the other breast, and obviously we do a risk assessment with them, that it's just the worst thing that could happen is somebody making a decision out of fear. But yes, unfortunately, breast cancer can recur locally, even in the frame of a mastectomy or a lumpectomy. Yeah, great question. Thank you. We recommend that women, I believe starting at 30, should have a high-risk screening assessment, but particularly with your friend who had breast cancer and has 3 daughters, for genetic testing, we usually would test the person with the diagnosis first. So then we would know if we have to test the daughters or not. Say your friend had a genetic test and it was clear, it was negative for a breast cancer gene mutation, like a BRCA1, like Angelina Jolie had, then the daughters wouldn't necessarily be tested unless maybe their father's side had a strong family history of breast cancer. But yeah, I would recommend that everybody, be evaluated for risk of breast cancer. Thank you, everybody. I appreciate you coming. Get your mammograms.
To learn more about Sun Health Foundation initiatives, become a donor, or attend a future Coffee Connections event live, please visit us online at sunhealthfoundation.org. or call 623-471-8500. Sun Health, empowering people to live longer, healthier, and more purposeful lives.